Hello, good morning. So, what are the topics in infection we have already covered? Yes. Anyone? क्या क्या पढ़ चुके हम? Malaria, tuberculosis, leprosy, cysticercosis. So now we'll be reading a little bit about pathology and pathogenesis of bacterial, viral, and protozoal helminthic diseases. So I'll be covering a part of it today, and another class will be allotted for another part, right? So viruses can cause many clinically important acute and chronic infections, and they can affect any organ system, right? So like respiratory organ system is affected by adenovirus, rhinovirus, influenza, respiratory syncytial virus. Digestive system is mainly affected by mumps, rotavirus, hepatitis. Skin eruptions are seen in measles, rubella, varicella zoster, herpes simplex. Hematopoietic disorders are caused by cytomegalo, Epstein-Barr virus. Okay, dengue, yellow fever, they cause hemorrhagic fevers. Skin genital warts are caused by papilloma, and poliovirus and JC virus affects the central nervous system mainly. So these are the various organ systems affected by different species of viruses, and these viruses can cause acute or chronic infections. So we will be reading some common and important viruses. So starting with measles. Measles causes acute viral infection, and that can affect multiple organs. The infections can be mild, self-limited to severe systemic manifestations. Measles virus are single-stranded RNA virus of paramyxovirus family, and this paramyxo family viruses also has the mumps, respiratory syncytial virus, parainfluenza virus, and human metapneumovirus. So these all infections are from paramyxovirus family. Okay, and the mode of transmission is by respiratory droplets. I can take the attendance, and those who want to leave can leave. Okay, attendance ले लो. If those who are interested, genuinely interested in the class, can stay back. At least there will be no whispering. ले लो attendance ले लो. Are you done? Class attend करना है? Yes? So just please don't talk. It causes disturbance in the middle. Yes? So measles is as I told you, measles is a single-stranded RNA virus of the paramyxo family, and it includes mumps virus, respiratory syncytial virus, parainfluenza virus, and the mode of transmission is by respiratory droplets. So it presents as blotchy reddish brown rash in the face, trunk, and the proximal extremities, and this rash is actually produced by dilated skin vessels, edema, and mononuclear perivascular infiltrate. So that gives the external, clinically it presents as blotchy reddish brown rash, and the involved part of the body is face, trunk, and proximal extremities. And pathognomic finding is Koplik spots and Wharton Fickledy cells. So what are Koplik spots? Clinically we see ulcerated mucosal lesions in the oral cavity near the opening of the Stenson duct. So these are Koplik spots, and in histopathology in the lymphoid organs we see marked follicular hyperplasia, large germinal centers, and multinucleated giant cells having eosinophilic nuclear and cytoplasmic inclusion bodies. These multinucleated giant cells having eosinophilic, what is eosinophilic? Pinkish, okay? Eosinophilic, which takes up the eosin stain. Nuclear and cytoplasmic inclusion bodies are called Warden-Finkeldy cells, and these are also pathognomic of measles. This is found only in measles, Koplik spots and Warden-Finkeldy cells. So this is a picture of these multinucleated giant cells, and if you can see in the these giant cells, you can see those nucleus, and they have pink, reddish pink nucleus. Can you appreciate those 1, 2, 3, and in there, okay, those round structures. So these are eosinophilic intranuclear inclusions, okay. So these are these Warden-Finkeldy bodies. So mumps. Next is mumps. Mumps is also another acute systemic viral infection, and it is associated with pain and swelling of salivary gland. Mostly it is bilateral. You must have seen clinically in your family, or even some patients you must have seen. So there is bilateral swelling of the salivary glands, and this is another member of Paramyxo family. So this is again spreads through inhalation of the respiratory droplets. How it enters? It enters the body through upper respiratory tract, but through inhalation of the droplets, and spreads to the draining lymph nodes, where they replicate in the lymphocytes, and then through the blood it spreads to the salivary gland and other glands. So in the salivary gland, it infects the salivary gland ductal epithelial cells, and that results in desquamation of the involved cells, edema and inflammation. This inflammation is associated with salivary gland pain and swelling. What are the cardinal signs of inflammation? Yes? Anyone? बताओ. Yes, say. बोलो. Pain. Pain, redness, loss of function, swelling, and okay. So, good. So inflammation that leads to classical salivary gland pain and swelling, right? So what are the clinical manifestations? Mumps causes parotitis. So bilateral in 70% of the cases. The glands, the parotid glands are enlarged, doughy in consistency, and on cut surface of the glands, the glands look moist, glistening, and reddish brown. In microscopy, we see there is edema, and there is infiltration by chronic inflammatory cells like macrophages, lymphocytes, plasma cells in the interstitium, and these inflammation, they compress the normal ducts and acini of the gland, and the ducts lumen are filled with neutrophils and necrotic debris, and these neutrophils, they causes damage to the lining epithelium of the ducts. So basically there is chronic inflammation of the gland, okay. Now second clinical presentation is mumps orchitis. So there is marked testicular swelling, and that is also caused by edema, mononuclear cell infiltration like macrophages, lymphocytes, plasma cells, and focal hemorrhages. This leads to testicular damage, and this testicular damage leads to scarring, atrophy, and if it is severe, it leads to sterility. Yes, which infection are we talking about? Mumps. And then, so parotitis, orchitis, then pancreas. Infection and damage of the acinar cells in the pancreas. This infection and damage of acinar cells in the pancreas will result in release of digestive enzymes, and these enzymes will cause parenchymal and fat necrosis and inflammation. Then mumps causes encephalitis, perivenous demyelination, myelination, and perivascular mononuclear cuffing is seen. Poliovirus. Poliovirus again causes mild self-limited infection to paralysis of limb muscles and respiratory muscles, and this virus is spherical unencapsulated RNA virus of the enterovirus genus, and it is transmitted by fecal-oral route. Now coming to herpes simplex virus, it is usually caused by herpes simplex virus 1 and 2. This virus replicates in the skin and mucous membrane at the site of initial inoculation. Okay, so it replicates in the skin and mucous membrane, and usually oropharynx or genital lesions are seen, and this causes a vesicular lesion. So vesicles are formed in the herpes simplex virus. After epithelial infection, virus spreads to the sensory neurons, and then by retrograde axonal transport to the sensory neuronal ganglia to establish latent infection. So this herpes simplex virus also causes latent infection. So the active infection may you see vesicular lesions, and it goes to the sensory neuron ganglia, and it is dormant there, and it establishes a latent infection. So after few years or months, it can also get reactivated and the infection can recur. So during reactivation, the virus spreads from the regional ganglia, that sensory neuron ganglia, back to the skin or mucous membrane, and again causes eruptions, vesicular eruptions. Okay. So these classical lesions include large pink-purple virion containing intranuclear inclusions. These are called Cowdery type A inclusions, as well as inclusion bearing multinucleated giant cells. Okay. So how it presents? It presents as cold sores or gingivostomatitis, that is oral inflammation around the oral orifice, to the life-threatening disseminated visceral infections and encephalitis. So it has a varied presentation. Fever, blisters or cold sores favor the facial skin around the mucosal orifice, lips, nose, okay, and frequently it is bilateral. You can also see these swollen erythematous lesions on the fingers or palm, and that is called herpetic whitlow, and that occurs in infants and occasionally in healthcare workers. And genital herpes more often caused by herpes simplex virus 2. So this is how it looks like. See, it is around the mucosal orifice, the mouth, right? So vesicles are formed. These vesicles can rupture and form ulcerations can be seen. Blisters can also be seen. So the next, can you see the nail there? Just beneath the nail you have some blisters. So that is herpetic whitlow. It is seen in infants and some healthcare workers. Okay. So herpes can cause corneal lesion. Neonatal herpes can be seen in neonates. Eczema herpeticum, Kaposi, varicilliform eruptions, encephalitis, esophagitis, bronchopneumonia, hepatitis. So multiple organs may be involved. In histopathology, what you see? You see a inclusion. So that is a big cell, okay, and that arrow is pointing towards the inclusion, the pink or purple intracellular inclusion in the cell, and that is surrounded by a halo. Can you appreciate the inclusion and which is surrounded by the halo? It is a eosinophilic inclusion, okay, and there are some dot-like structures outside the inclusion. Can you see that? Just outside the halo, some dots, small dots. They are virions, intact or disrupted virions can be seen, and they have eosinophilic inclusions. So, and these are called Cowdery type A inclusions. Now coming to varicella zoster virus. Acute infection with varicella zoster virus causes chickenpox, and reactivation of latent varicella like herpes simplex virus. Varicella zoster can also be be in a latent state in the body, and it can get reactivated. So reactivation of the latent varicella zoster virus causes shingles, which is also called as herpes zoster. So don't confuse between herpes simplex and herpes zoster. It is mild in children but more severe in adults and immunocompromised persons. It affects the mucous membranes, skin and neurons, and causes a self-limited primary infection in the immunocompetent individuals, in which the person is not immunocompromised. Okay, so the infection is self-limited, it is not severe. The rash, approximately it occurs after 2 weeks after the respiratory infection. So person presents with cold, cough, soreness of throat, and the rash appears approximately after 2 weeks. Lesion appears centrifugally from torso to the head. So it affects the body, the central part, and then it spreads to the extremities, head, and to the head. Okay. So this is a very characteristic presentation of chickenpox, and each lesion progresses rapidly from a macule to a vesicle. So, and this vesicle resembles like a dewdrop. Okay, so the lesions have different stages of presentation. Some lesion may appear as vesicle, some lesion may be just a macule. So you can see a varied presentation. On microscopy, we see intraepithelial vesicles with intranuclear inclusions. Usually the viral infections will present with inclusions in the epithelial cells at the base of the vesicles. After a few days, what happens is vesicles rupture, crust formation takes place, and they heal by regeneration, and there is no scarring. Usually there is no scarring. But when there is a trauma, when there is rupture by some kind of trauma or by finger pricking the vesicles, and after that, if there is a bacterial superinfection of the vesicles, okay, there is destruction of the basal epidermal layer, and that results in residual scarring. That is the reason why we say when there is a chickenpox, don't rupture the vesicles by yourself, right? Because there will be bacterial superinfection and destruction of the basal epidermal layer and residual scarring. Now shingles, also called as herpes zoster. They occurs after reactivation of the latent varicella zoster virus in the dorsal root ganglia. These also causes vesicular lesions, but these have intense itching, burning or sharp pain is there because of concomitant radiculoneuritis. In varicella chickenpox, there is no pain as such, but in shingles there is sharp pain because of radiculoneuritis. There is nerve involvement, and this we can see facial paralysis. So what happens? What is this called as? Ramsay-Hunt syndrome. Okay. And what is the difference? What did I tell you now? Yes, you. Just the last line which I spoke. And beside you. What is it? Huh? Facial paralysis. In what? Which virus am I talking about? Sit down. Varicella zoster virus also causes interstitial pneumonia, encephalitis, transverse myelitis, necrotizing visceral lesions, particularly in immunosuppressed people. Coming to cytomegalovirus, this can also produce, this is a group of herpes virus, and this can produce various disease manifestations depending upon the age of the host and host immune status, immunocompetent or immunocompromised. It depends upon that how the clinical manifestations will depending upon that variety of clinical disease manifestations will happen, and it may cause asymptomatic or mononucleosis like infection in healthy individuals. So if in case of immunocompetent individuals, the infection may be asymptomatic or maybe just a mild viral infection, or in immunocompromised people or neonates, it may present with systemic infections and they will affect different cell types. CMV infects monocytes and their bone marrow progenitors and can be reactivated when cellular immunity is depressed. It can be latently. This virus can also present in a latent state in monocytes and bone marrow progenitors and can be reactivated whenever the person's immunity is low. So how the CMV transmission takes place? Through transplacental transmission. It is also called as congenital CMV. Neonatal transmission through the cervical or vaginal secretions at birth or through breast milk from a mother who has an active infection. That is called perinatal CMV. Transmission through saliva. Transmission by genital route, respiratory secretions or fecal-oral route, and iatrogenic transmission. So in this again you see inclusions. What do you mean by CMV? What is the full form? So what do you mean by cytomegalo? Cell size will increase. The size of the cell is enlargement of the infected cells, you can see, and prominent intranuclear basophilic inclusions. So what is the difference in herpes simplex and CMV? In herpes simplex you see eosinophilic inclusions, and in CMV you see basophilic inclusions. Okay, so that is the cells are strikingly enlarged, gigantism, and this is again surrounded by a clear halo, and you can see some sort of pleomorphism. So here you can see another that is the whole cell, and you can see some inclusions there. Okay, and there above you have two inclusions, so the pointed ones. So most common clinical manifestation of CMV infection is immunocompetent host who is beyond the neonatal period, in whom immune status is good. They present with infectious mononucleosis like illness with fever, atypical lymphocytosis, lymphadenopathy, hepatitis sometimes marked by hepatomegaly, and abnormal liver function test. Coming to Epstein-Barr virus, it also has varied presentation. It can be benign. It can cause benign self-limited lymphoproliferative disorder. 2, it can also cause certain lymphomas, even nasopharyngeal carcinomas. Okay, and it is characterized by fever, sore throat, generalized lymphadenopathy, splenomegaly, and you can see atypical activated T lymphocytes, that is called mononucleosis cells in the peripheral blood film. Some people can develop hepatitis, meningoencephalitis, and pneumonitis, and it is transmitted frequently through saliva by close human contact. It usually infects the B cells and epithelial cells of the oropharynx. So through saliva it enters the body, the viral is ingested and affects the epithelial cells of the oropharynx, and then subsequently it infects the B cells, and it causes infectious mononucleosis, in which we see lymphadenitis, and we can also see hepatitis, splenitis, pneumonitis, meningitis, encephalitis. Okay, and Burkitt lymphoma. Epstein-Barr virus can also cause Burkitt lymphoma. Okay, So it has lot of benign manifestations as well as malignant manifestations as well as nasopharyngeal carcinoma. Okay. So it affects blood, lymph nodes, spleen, liver, CNS, and occasionally some other organs. And we see mostly absolute lymphocytosis. More than 60% of lymphocytes are seen. Large atypical lymphocytes are seen. These atypical lymphocytes are characterized by abundant cytoplasm. What happened? Abundant cytoplasm containing multiple nuclear clear vacuolations, an oval indented or folded nucleus, and scattered cytoplasmic azurophilic granules. So these are the atypical lymphocytes. Usually how a lymphocyte looks like. Yes? How a lymphocyte looks like. Does it have abundant cytoplasm? And how is the nucleus? Yes? Okay. Single, multiple? Okay. And a scanty rim of cytoplasm. So in this atypical lymphocytes you have abundant cytoplasm and even vacuole formations are seen. Okay. And the nucleus is folded, indented, and some granules are seen in the cytoplasm. Okay. Now lymph nodes are enlarged throughout the body. Most commonly posterior cervical, axilla, and inguinal regions are affected. In microscopy, what we see, there is expansion of paracortical areas because the T cells are activated. Okay, and you can also see some infected B cells are resembling Reed-Sternberg cells. Okay, they are not actual Reed-Sternberg cells, they are pseudo Reed-Sternberg cells. Where do you see Reed-Sternberg cells actually? Hodgkin's. Okay, and you have splenomegaly in most of the cases, and you also have moderate hepatomegaly due to these atypical lymphocytes. They can be seen in the portal areas and sinusoids. Okay. Now the diagnosis depends upon the following findings: lymphocytosis with the characteristic atypical lymphocytes in the peripheral blood, if you see this, or a positive heterophile antibody reaction, that is also called as monospot test, a rising titer of specific antibodies of the Epstein-Barr virus antigens. Now coming to gram-positive organism. So common gram-positive pathogens include Staphylococcus, Streptococcus, Enterococcus. Okay. Diphtheria, Listeriosis, Anthrax, and Nocardiosis are also less common, and these Staphylococcus, Streptococcus, and Enterococcus are more common. These Staphylococcus aureus infections, they cause a variety of skin lesions: boils, carbuncles, impetigo, scalded skin syndrome. Also they can cause abscesses, sepsis, osteomyelitis, pneumonia, endocarditis, food poisoning, toxic shock syndrome. So they cause variety of lesions and abscess, sepsis. They cause pyogenic tissue destruction. What do you mean by pyogenic tissue destruction? Pus formation. So they are gram-positive cocci that forms clusters resembling bunches of grapes. Usually these skin infections caused by Staphylococcus are centered around the hair follicles. Okay, and from these hair follicles they begin. Lesion is located in the skin, lungs, bones, or heart valves, and they cause pyogenic inflammation, and this pyogenic inflammation causes local destruction of the host tissue. You will see impetigo, where the infection is restricted to the superficial epidermis. Boil is also called as furuncle, and it is a focal suppurative inflammation of the skin and subcutaneous tissue, solitary or it can be multiple in successive crops. You might have witnessed this boil, it is very common. and it is mostly frequent in moist, hairy areas such as face, axilla, groin, legs, and submammary folds. Beginning in a single hair follicle, this boil, they grow and they develop into abscesses, and the tip, then there's center, the head develops in the center, and there's thinning and rupturing of the overlying skin, releasing the pus. And the next, after furuncle, we also see carbuncle. So carbuncle is deeper, furuncle is superficial, and carbuncle causes deeper suppurative infection. So they spread beneath the deep subcutaneous fascia and burrows superficially through multiple sinuses. So it extends in the deep subcutaneous region, and it burrows superficially through sinuses, multiple sinuses. Carbuncles are most commonly seen in the upper back and posterior neck. Then next infection is hidradenitis. It is the infection of the apocrine glands seen in the axilla. We can then there is next is paronychia. What is paronychia? Some of you might have seen the infection of the nail bed. Okay, so that is paronychia, or on the palmar side of the fingertips. That is called phelons. These are all caused by Staphylococcus. These are very painful. They follow trauma or embedded splinters, and if it in severe cases, they may destroy the bone of the terminal phalanx or detach the fingernail. It can also cause lung infections, and we see polymorphoneutrophilic inflammation mainly, and leads to tissue destruction. This usually arises from hematogenous spread source such as infected thrombus, or in the setting of a predisposing condition like influenza. Staphylococcus can also present as Staphylococcus scalded skin syndrome, also called as Ritter disease. Okay, so how patient presents? Patient presents as sunburn like rash that spreads over the entire body and evolves into fragile bulla. So there is many bulla formation. You know what is bulla? If the size vesicles are smaller and bulla is large, and it is who said bulla? It can rupture very easily. Okay, so there's fragile bulla, sunburn like rash. It spreads throughout the body. It is present in the entire body and evolves into fragile bulla that leads to partial or total skin loss, and there is desquamation of the skin, the epidermis, in Staphylococcus scalded skin syndrome. So that is why the name. Now coming to streptococcal and enterococcal infections. Streptococci can also cause suppurative infections of the skin, oropharynx, lungs, and heart valves, and it also causes number of post-infectious syndromes like rheumatic fever. It is a part of many post-infectious syndromes: rheumatic fever, immunocomplex glomerulonephritis, erythema nodosum. It is a gram-positive cocci that grow in pairs or in chains. Okay, so beta hemolytic streptococci is typed group A, group B. Okay, it is typed into these groups according to the surface carbohydrate antigens. These are called Lancefield antigens. So group A, Streptococcus pyogenes, causes pharyngitis, scarlet fever, erysipelas, impetigo, rheumatic fever, toxic shock syndrome, and glomerulonephritis. Group B colonizes the female genital tract and causes sepsis, meningitis in neonates, and chorioamnionitis in pregnancy. Streptococcus pneumonia is the most important alpha hemolytic streptococcus and is common cause of community acquired pneumonia in older adults and meningitis in children. Okay, next is Viridin's group of streptococci. These include alpha hemolytic and non-hemolytic streptococci, and these are found in normal oral flora. Okay, and these are they cause endocarditis. Streptococcus mutans is major cause of dental caries. You get lot of MCQs in these during your post after you finish from here. Go to MD जब करना होगा तो you'll get lot of MCQs. Streptococcal infections are diagnosed by cultures and by rapid streptococcal antigen test. Enterococci are gram-positive cocci that grow in chains, and Enterococcus is resistant to commonly used antibiotics. They are resistant, and they usually cause endocarditis and UTI, urinary tract infections. So these are the various presentations of streptococci. Meningitis, starting from above, meningitis in the mouth, ulcers, pharyngitis, pneumonia, lung abscess, glomerulonephritis, purpural sepsis, impetigo. So this also presents with interstitial neutrophilic inflammation like staphylococcus, but it is lesser in severity compared to staphylococcus. So it causes minimal destruction of host tissues. Unlike staphylococcus, it causes extensive destruction of host tissues. The skin lesions by streptococci like staphylococcus are furuncles, carbuncles, impetigo. Erysipelas is caused by the exotoxins from superficial infection with Streptococcus pyogenes, and these are characterized by rapidly spreading erythematous cutaneous swelling. Okay, and here in the Streptococcus, the erysipelas, the rash are sharp, well demarcated, have serpentinous borders, and may form a butterfly-like distribution on the face. So in the next class I'll show some more pictures on these streptococcus, some more clinical pictures, I mean mumps, measles, whatever I have taught you till now will cover the rest of the bacteria and protozoal and helminthic infections. Okay, thank you.